I hope everyone enjoyed session three. It was great learning about the postpartum hypertension clinic and the cardiometabolic clinic. Now we're going to pivot a little bit and talk about stroke prevention and response in maternal health. This session will really highlight key updates from the newly released American Heart Association stroke guidelines and the scientific statement and their relevance to maternal health across pregnancy and the postpartum period. So we're really excited for what we have in store for you all. As a reminder, throughout the session, you will have the opportunity to submit your questions to our speaker using the question feature on your control panel. You could also send in your questions at any time, and we will review the questions during our Q&A as time allows. And to access live closed captioning, please click on the closed caption button found on your screen. And as a reminder, all sessions will be recorded and available in the coming weeks on our initiative website. So it is my pleasure to introduce our speaker for today. Dr. Carolyn Zelup is a maternal fetal medicine specialist, director of fetal echocardiography and perinatal research at Valley Health System, and clinical professor of OB-GYN at the NYU Grossman School of Medicine. As a reminder, full speaker bios are available at the event lobby. Dr. Zelup, it is my pleasure to welcome you to session four.
I am here. Thank you for that kind introduction and allowing me to join the conversation. It's been a real privilege to work with this fantastic team promoting pregnancy health, particularly in the postpartum and interconception care arenas. So May is Preeclampsia Awareness Month, but it's also American Stroke Month. And to set the stage for our discussion today, I'm going to begin with some statistics. So every 40 seconds, someone in the United States has a stroke. Importantly, stroke is the number 3 cause of death in women, and stroke happens more frequently in women. But also importantly, stroke increases in women who are pregnant, and particularly in women who have hypertensive complications of pregnancy. So let's take a deeper dive and explore why those healthcare professionals in the pregnancy space really need to learn about stroke. What is stroke? Stroke is a situation in which there is acute interruption of blood supply to the brain. And when you interrupt blood supply to the brain, you deprive the brain of oxygen and crucial nutrients, but you also leave toxins behind. If the interruption is not acutely resolved and reperfusion does not occur, then the tissue will die and there will be loss of function and even potentially death. So I hope today with our discussion to emphasize why maternal stroke deserves urgent attention. And the American Heart has responded to this call to action, by releasing a new scientific statement. Stroke is not common in pregnancy or in young women, but pregnancy does put women at a higher risk for stroke. And it's interesting because stroke is decreasing in other patient populations, but paradoxically, the rate in pregnancy is increasing. Stroke can cause some catastrophic consequences in pregnancy or in the postpartum period. It accounts for 46% of maternal deaths. This may be actually an underestimation since some of these may be classified as hypertensive disorder complications. So as I mentioned, there's a new scientific statement released about prevention, treatment of maternal stroke in pregnancy and postpartum periods. The American Heart collaborated with other stakeholders, such as the American College of OBGYN. The scientific statement represents a multidisciplinary effort to synthesize current knowledge of the risk factors and diverse causes of stroke in pregnancy, and to offer consensus-driven suggestions for prevention, acute management, and postpartum recovery. The new scientific statement emphasizes, importantly, aggressive blood pressure control, early recognition of stroke symptoms, and prompt treatment for pregnant and postpartum women. So you may be wondering, what does pregnancy have to do with stroke? And why is it important for those in the pregnancy space to understand stroke risk factors and stroke recognition? The physiologic changes, I may remind you, make pregnancy possible, but they also create the potential for vulnerabilities and medical complications, one of which is stroke. And it's really the hormonal milieu that's driving some of the issues. Importantly, estrogen, which is so prevalent and necessary for pregnancy, has a downside. It creates the tendency to clot. Now, this is a good thing because we're preparing for the physiologic hemorrhage at delivery, but it also increases the risk for clotting, which can lead to stroke. Also, progesterone, which relaxes the uterus and allows pregnancy to develop, unfortunately, can cause remodeling in the vascular system. And this remodeling, while it increases compliance, it also makes the vessels more reactive and more fragile, thus making them susceptible to wall tension damage. So there are other classical pregnancy-associated stroke risk factors, and these are some of the same factors we see outside of pregnancy. Hypertension, older age, but in pregnancy, that's relatively young. It's 35 years or older. Diabetes, obesity, migraine, especially migraine with aura, infection, heart conditions, cerebral vascular disease. We learned that pregnancy from Dr. Bond, this is a cardiopulmonary stress test, and it may be the first time that these complications are unmasked. Pregnancy also, as I mentioned, increases the tendency to clot and also prevents clots from dissolving. So continuing on in our discussion and understanding of the mechanisms of maternal stroke, let's look a little bit about the anatomy. This is a schematic, but it helps me tell you some important aspects about stroke and pregnancy. One of them is that compared to the non-pregnant state, hemorrhagic stroke is more common than ischemic stroke. And there are some interesting variations of the type of stroke you will see in pregnancy, uniquely related to the loss of autoregulation of blood flow in those experiencing hypertensive complications of pregnancy. Stroke can occur on the venous side as well as the arterial side. And it can occur in the layers as well as the parenchyma of the brain itself. You can also see intracranial hemorrhage, and also subarachnoid hemorrhage. And we'll talk a little bit more of these and about all of this in the next few slides. So let's try to approach it in layers and put it all together. I've talked about the traditional risk factors. There are other risk factors that are sometimes more relevant in pregnancy, particularly the hypertensive disorders of pregnancy. And then we want to then superimpose this on the physiologic changes of pregnancy. And what happens? We've got the perfect storm, which is pregnancy leading to stroke. So as a review, we have hemodynamic changes. Yes, cardiac output increases. We've got vascular remodeling, but that leads to more vascular reactivity and vulnerability. We have also endothelial dysfunction, which then can lead to capillary permeability and vasogenic edema. And we also have immunological modulation so that the fetus is not rejected, but particularly in the setting of infections, for example, you've got cytokine surges, which leads to platelet aggregation. And lastly, as I've mentioned before, we have a hypercoagulable state that's done to prevent and prepare for the bleeding that occurs at delivery, but it also increases the risk for stroke. So let's look at a few examples of stroke neuroimaging in pregnancy. And in A, you will see this is a CT scan, and you'll see an example of intracerebral hemorrhage. This unfortunately occurred in the postpartum period in a patient with HELLP syndrome who had low platelets. HELLP is a variant of severe preeclampsia. And this patient also had extremely high blood pressures, which led to intracerebral hemorrhage. In B, we see an example of ischemic stroke, and this happened in a patient that had an undiagnosed patent foramen ovale, and through a paradoxical embolism, sustained an ischemic stroke. In C and D, we see some unusual examples of stroke, and these happen more in those with preeclampsia specifically. And one of them, as demonstrated in C, and this is an MRI, we have an evidence of the posterior reversible encephalopathy syndrome, or PRES. And this is a result of vasogenic edema, which is a diffuse process, but usually thought to be more concentrated in the posterior aspect of the brain, affecting vision. But it can also lead to stroke in other aspects of the brain. In D, we see the reversible cerebral vasoconstrictive syndrome. And here we have both vasospasm leading to clot and hemorrhage. Again, these complications are seen more frequently in the setting of hypertensive complications, specifically in preeclampsia and eclampsia. So importantly, I hope I'm building an argument for you to all understand about why all healthcare professionals in the pregnant arena need to understand the warning signs of stroke, because you're going to hear me say this over and over again for the last 10 minutes, brain is time in the setting of stroke. So we have to be fast. We have to recognize subtle neurological changes, and then we have to act and engage the healthcare system, the emergency healthcare system, because time is of an essence to establish a diagnosis, find out where the blockage is, and then begin treatment. So time is brain. And this is a busy slide, but it's busy because that's the way the management of stroke has to be. And the management of stroke outside of pregnancy and during pregnancy are very similar. Yes, we do have two patients, but we need to find and where the blockage is through early recognition, through early imaging, early interfacing with the emergency department, and getting care that is multidisciplinary in a stroke center. So we need to have endovascular thrombolysis. And the thrombolysis can either be accomplished in two ways. You can have a thrombectomy and remove the clot, or you can dissolve the clot. Both can be done outside of pregnancy and even during pregnancy. And one of the reasons why we're going through all this is because we want to emphasize that care should not differ or be withheld for the pregnant patient. This is where lives are lost and disability or death occurs. So time is brain. And let's just briefly review again the algorithm for stroke management. We've got to recognize subtle neurological changes, signs and symptoms of stroke, quickly assess the neurological system through imaging, make a diagnosis. Is this hemorrhagic or thrombotic? And then what kind of treatment needs to be initiated? Do we use thrombolytics? Time is of the essence. If it's hemorrhagic, we don't want to use thrombolytics. We want to stabilize vital signs and monitor for increased intracranial pressure. We want to evacuate large hematomas and surgically clip the source of bleeding, which could be an aneurysm, so a weakening, an expansion in the vessel wall, or it could be an arterial venous malformation rupture. I seem to have lost my slides. I'm hoping that we can resurrect them. So there's more about time is brain. And what I've listed is some key times, thank you, that are time metrics that stroke centers have to aspire to. And this is to initiate prompt treatment and get the best patient outcomes. So there are get with the guidelines for stroke. Clinician evaluation within 10 minutes. Within 20 minutes of arrival to the emergency room, imaging is performed. Within 45 minutes of arrival to the emergency room, imaging must be interrupted. Within 60 minutes of arrival to the emergency room, medications or interventions should be carried out, such as thrombectomy of a larger vessel. And within 3 hours from onset of symptoms, stroke admission should occur to the ICU. We're getting there. So again, to emphasize, pregnancy is not a reason to delay or interfere with recommended treatment for acute stroke. There are various anti-clotting medications available that are safe for pregnancy and lactating women. The management of stroke should be carried out by a multidisciplinary stroke team involving a variety of specialists and subspecialists. The goal of management is prevention, treatment, and initiation of recovery. So what are the steps for stroke prevention during pregnancy and the postpartum period? As we've been discussing today, it actually should start before pregnancy and even after pregnancy in the interconception period. We need to follow life's essential 8, including smoking cessation, healthy diet, physical activity, weight control, blood pressure control, glucose control. All of these are paramount for reducing the risk of stroke. Hypertension, as I mentioned, should be very strongly monitored as well as controlled. In summary, the management strategies should include antihypertensive therapy to prevent severe hypertension. Low-dose aspirin reduces the risk of preeclampsia, and tighter blood pressure control, particularly in the postpartum period where we know that stroke is most prevalent. It's actually day 8. So it's going to be the time when the patient has most likely gone home, especially in a normal, otherwise uncomplicated delivery. And we've shown that if blood pressure is better controlled, there's going to be less readmissions and less emergency room visits. So let me finish with key takeaway points. The physiological changes of pregnancy and complications of pregnancy increase the risk of stroke. I'm sure many of you don't necessarily make that association, but after our discussion today, I hope that you remember that important fact. Pregnancy should not delay evidence-based treatment of stroke. Stroke in pregnancy requires multidisciplinary team management. Neuroimaging modalities are effective and safe for rapid evaluation of pregnant patients with stroke-like symptoms. There should be no concern in withholding CT or MRI or CT with angiography. Goals are evaluation and stabilization of pregnant patients so that acute stroke does not signal immediate delivery. This is very important to understand. Maternal stabilization is paramount. Post-stroke pregnancy victims and their family face an uphill battle, and they need a multidisciplinary team that is willing to work with them and begin a comprehensive rehabilitation process. We've learned that knowledge gaps are significant and require ongoing inclusive research to drive innovative care that ultimately improves outcomes for pregnancy and the offspring of the patient. I think I'll stop there, and if there are any questions, happy to address them.
Dr. Zella, thank you so much for guiding us through stroke prevention and maternal health and pregnancy. I know for some of us, it's a little bit of a newer topic, so really appreciate you guiding us through that discussion. I think we have time for a couple of questions from the audience. So one of our questions asked, at what point post-delivery is it safe to administer TNK?
Actually, it can be given during pregnancy. If you're thinking about the postpartum patient, you may have to address whether they've had a cesarean, for example, how far out they are from their cesarean birth, if that's what they had. So it's on a case-by-case basis. But I want to emphasize that during pregnancy and after pregnancy, we can use thrombolysis.
Great. Thanks so much, Dr. Zella. We have one more question. It seems like maybe it's asking us around maybe the differences in CT, brain, and neck with contrast during the 3 trimesters of pregnancy.
So generally speaking, we want to avoid gadolinium, for example, which is used with MRI, but CT can be used with contrast. The contrast is different.
Great. Thanks so much, Dr. Zellup. Well, I think that's all the time we have for
Thank you
our
so much for
questions.
having me.
Thank you so much, Dr. Zellup. Coming up next at 11:55 a.m., so in about 5 minutes, we have our fifth session, which is on midwife and doula care models and postpartum care. You can access this session if we return back to the lobby using the menu at the top of your screen. From the lobby, you'll click on the sessions tab first, then click on the individual session that says midwife and doula care and models and postpartum care. We also posted it in the link as well, so you can use that to go directly to that next session. But again, thank you so much, Dr. Zellup. Thank you all so much for joining today's session on stroke prevention and maternal health. We'll see you in the next session. Thank you.
Thank you.